pandemic, COVID-19, have intensified the demand for medical attention. However, the governments have limited fiscal income, high levels of indebtedness, and the sequels of global crisis. In spite of these challenges, it is possible and also necessary to give an answer. Our region could achieve more health, more equality, and more financial protection by promoting or by ensuring that investment in health is more intelligent, is smarter. In other words, purchasing adequate health resources inputs, lowering waste. This is the focus of our new report. It is based on experience and the studies of the Division of Social Protection and Health of the IDB and of our knowledge network and criteria together with its partners. The publication includes clear concepts such as the prioritization of explicit controls and health strategies, as well as strategies to manage and purchase better the supplies, medications, as well as the disinvestment in interventions that do not imply an improvement in health. Governance, transparency, and accountability also play an important role, a fundamental role. More and more governments are acknowledging the benefits of investing smarter in health. The challenge ahead of us is to develop and adopt policies that will promote more efficient health spending, in which every resource invested in health counts. We invite you to read and share this new report. Together, we can create a future in which access to quality health is a reality for more people in a more equitable way and without financial difficulties for the countries of the region. Accompany us on this pathway.
Muy buenos días y buenos días a todos y a todas. Muy buenas
Good morning,
tardes.
everyone. Good afternoon as well. Thank you very much for accompanying us both in person as well as online in the launching of this flagship publication, Smart Spending for Health, How to Make Each Dollar Count. I see many people from our region connected to this section, and I think that this actually shows the importance of this topic, to use the resources available in the health sector in the most efficient way possible, in the most intelligent way possible, to achieve greater health equality, financial protection for the citizens of our region. So to me, it is a pleasure to be here to accompany you in this session. My name is Marcela Distrutti. I'm health specialist in the bank. I'm also part of the criteria team, which is a knowledge network of the Division of Social Protection and Health of the bank. And to me, it is a great pleasure because this publication shares a lot of the work that we have been carrying out through criteria during the past 10 years. So it's a pleasure to be here with all of you. I would now, to begin this session, like to invite our colleague, Via Salvador, to present this flagship publication on the different strategies to have smart spending for health. He's a senior partner in social insight and also an ex-colleague of the bank, and it's a pleasure to have him here once again back home. So thank you. Thank you for being here. Thank you, Marcela. Good morning.
Listeners in the net world out there, I can't tell you what an honor it is for me to be speaking at this time about this publication. And in a room that not only has many people I don't know, but many friends and many people who I worked with intensely online for months during the COVID pandemic. And it's just so strange to have worked with somebody daily, like up till midnight for 3 or 4 months. And then it's 3 years later and you see them in person and you realize that they're actually a foot taller than you imagined. But it's great to be here in person. I also want to thank the bank for the opportunity to be a collaborator on this publication. It's usual in a case like this to recognize co-authors, and the co-authors on this were fabulous. You have Ursula Gideon, Pamela Gongora, Marcela Distrutti, who introduced me, were key to making this publication and writing it and bringing out how it was. What I might say is unusual about this publication is that it also has about 1,000 other co-authors. Because this comes out of, depending on how you want to look at the time scale, the last 10 years of work by the Red Criteria, which was a network set up in the IDB to support the introduction of smarter spending in health in the region. And it's produced an enormous amount of material, and this book is essentially a guide that highlights where you can go to find these different resources from Criteria. If you expand the time frame a bit more, this is really part of a 20-year framing of looking for ways to make spending smarter in health through different kinds of concepts, tools, research and analysis, and policy work. And you could go back to 50 years where concepts of measuring health quality, measuring what a life year is, measuring what we're trying to achieve with health, debates over whether we should even measure health or not. All these things have been going on for 50 years. So this publication really is just at the apex of a huge body of research and material, and wouldn't be possible without it. What's interesting also is that despite having so many authors, co-authors, it's really all about one very simple idea. All of the people, all those thousands of people are working on one simple idea. And that's, can we be smarter about how we spend money on health in order to achieve our health goals? And you've heard it from Pablo and from Marcela. Can we give more people more health, more equitably, and with more financial protection? That's what it comes down to. And it may require more money, but even if we're spending more money, we want to make sure that money isn't going into wasteful practices or into less effective practices. We want to make sure that every dollar currently spent and the dollars that come, or the pesos, are effective at what we care about, which is the health of the people around us, the equity of our society, and our bienestar, our well-being. And I don't want to go on without saying one more thing, which is these are essential. We talk about efficiency, and people say, well, why do we care about cost? But health is a human right. Why are we talking about money? We need universal health coverage. Well, efficiency, a system that does not have efficiency, no matter how much you spend on it, will never be able to realize people's rights to health, and will never be able to reach universal health care, no matter how wealthy that country is. So efficiency, smart spending are really, when used well, they're part of the package of realizing the right to health and making progress toward universal health coverage. So with that, let me talk a little bit about the publication. I was a little disappointed to see Pablo's video because he already gave you the executive summary and there may not be much more to say. There we go. I'm going to talk a little bit about why we care about health spending. I've said some about that, what it is, and then how we do it. Now, the people in this room have already spent about 2.5 days talking about smarter health spending along a variety of dimensions. So I'm going to try to focus on the ones in this report that you did not address. But many of the things you talked about here would also fit under smart spending and how to do it. And toward the end, I'll talk about the political economy of this, something that our previous speaker, Anya Sukat, just mentioned. Oops, went too far. So just to get across the point of why we need to think about smart spending in health, this chart shows you spending across the x-axis and child mortality across the y-axis. And you can get a lot of information from this. Different countries are at different places on this diagram. But what I wanted to point out is that if you pick out a country that's low, like I'm looking at El Salvador and Ecuador. Their spending's around $500 per capita. And their infant child mortality rate is about 10 per I'm forgetting about the units. 100,000? 10 per 1,000. 10,000. 100,000. So that's where they are at. If you look up, you find countries that are spending about the same, but have child mortality rates that are 3 to 5 times higher. Now, all health spending is not about child mortality. So this is really just an illustration of a more robust statistical analysis that when researchers look at the relationship between what countries are spending and what kind of health outcomes they find, the differences are very large, and they can't be explained just by the epidemiology, the demographics, or other kinds of things. There's a large part that's unexplained, and basically that large unexplained category is how well they're spending the money. How effectively do they transform the money that they spend into the services, into the prevention, into the health promotion, and into the treatments that help people live longer, better lives. As Pablo also mentioned very concisely in the video, this takes a special urgency right now because money is hard to come by. It's always hard to come by in the public sector. You need to mobilize revenues and more taxes in Latin America and the Caribbean generally. But this chart is showing you the results of a study that was done for the IDB by Johns Hopkins University group about where health spending is going in the region. And this was prior to the pandemic, expecting overall about 3% growth annually through 2005 in health spending in the Latin American countries and 4.5% annually in the Caribbean. But an important part of or probably the most important contribution here isn't the predictions, because predictions are always wrong. It's the exercise of analyzing where are the major cost drivers. And the key point here is that, yes, populations are aging. Yes, in some countries, certain diseases, non-communicable diseases are increasing in many countries. But really, it's technology that's driving the increases in health spending. And to the extent that that technological change is improving health, that's great. More spending on technologies that improve health, that's good. But if it's technological change that's not improving health, worse yet, if it's technology that's making health worse, or if it's technology that brings very little health gain for huge costs and displaces other more effective spending, then it's not helpful. And unfortunately, throughout the world, rich and poor, that kind of technological advance doesn't really generate as much health proportionally to the cost is actually quite common. So that's the motivation. Most countries are heavily indebted. Fiscal constraints are tight. The pandemic gave us more health demands, made it clear we need to spend more on preventing infectious disease, surveillance, epidemiology, all these kinds of things that we have as new demands, and all the old factors that are continuing to drive health spending up. What is smart health spending? How can we spend smarter in health? Well, smart health spending is getting more health value for the dollars and the pesos that you spend. For a given budget, can you get more health? The answer almost universally is yes. And there are two steps to this. One is a social debate and a dialogue about what countries really want to get out of their health spending. I mean, if what countries want is sophisticated hospitals to treat people and they really don't care about other kinds of illnesses, and if you want a health promotion or something like that, that's really their health value. But most countries see health impact for the population as the key thing, and will include things like equity, financial protection, compassion for the disadvantaged, these other social and ethical aspirations as part of the question. And though there are many ways to make spending smarter, I'm going to focus on three things that we emphasize in the publication: buying the right things, spending less on the wrong things, and getting better deals. In terms of spending money on the right things and not on the wrong things, there's a whole series of tools that look at cost effectiveness. How much health do you get for each dollar you spend on drug A versus drug B, on this kind of treatment versus that kind of treatment, on treating this illness versus that illness, that can inform policy. I'm not saying that it decides policy, but it's a piece of information, and I'll explain a little bit about that. Opportunity costs that acknowledge the trade-offs that are implicit in these decisions. Health technology assessments, which are institutions that build this kind of information and can play a key role in the social discussion and debates about what to finance. The design and use of health benefit packages, which make explicit what is included or what is not included in what the health sector will pay for. Disinvesting in services with little or no health gain, identifying the places where waste is really problematic, reducing operational and administrative waste, and reducing fraud, abuse, corruption, and conflicts of interest. These are all things at the end there, three, that add to costs without helping anybody, without improving health at all. I want to emphasize sort of one example of the opportunity cost, which is a concept that what's important in looking at healthcare decisions when you're spending money is not only the cost, not just the dollar cost of what you're spending, but what other things could you have spent on that might have improved health. And here's an example from a calculation done in the Dominican Republic about a drug for second-line renal cancer. Compared to the alternative, there is an existing treatment for this, but a new drug comes in and says this is better. And looking at spending on this new drug and the marginal benefit it adds compared to screening and managing type 2 diabetes, which is much more widespread and, as you can see from the figures, much cheaper per case to treat. And down the line, you're seeing the cancer treatment is covering many fewer people. Its cost is multiples above $18,000, $19,000 per case compared to $700 for the people with diabetes. Generates half as much additional healthy lifetime. And if you just took a look at how many health days you get for a $100,000 budget, it's $500 in the case of the people with renal cancer and $28,000 for the people with type 2 diabetes. Now, those are the numbers, and as Agnes pointed out, numbers are not what we decide on, but it provides a stark contrast of the trade-off. So if you only have $100,000 and you choose to go for the cancer line treatment, which you might because you're really concerned about the disadvantaged group or something about that group, you can do that. And you must do that knowing that there's a consequence. These are the other people who are not getting healthy lifetime. And that's what an opportunity cost is. And it's a hard thing to look at. People don't want to look at it. But when we're making public health decisions, allocating money across things, this is essentially what we're doing. And the message I'll try to get at the end is this has to be brought to the attention of the public. It's not just for technical and politicians. It has to be the public that understands what these kinds of choices are about. There's a whole, I could go on about that, but obviously, that's, we've already spent 2.5 days on a whole series of these things. I'm not going to go that far. I want to go on to the question of, can we get better deals? A lot of times we forget that the government is buying things it can buy better. And even individuals can buy better. In the case of government, better administration and management of procurement can get a lot of gain. Pooling procurement, buying in larger volumes, regulating prices, promoting competition, or, and I'll talk a little about paying lower prices for similar products or services. it is a business in some ways, the healthcare business. You can buy inputs, medications, cotton swabs, sugar solution. These are things that are sold on markets. If it's in a competitive market, you should be able to get it for better prices. Here's just two examples of buying better. On the left-hand side, there's a study that was done of about 13 countries. This is a Center for Global Development study. And they grouped the countries by the kinds of procurement system they had. The ones on the far left, Kerala and Thailand, buy in larger volumes. They preferentially buy generics. And they have a whole series of other things to buy local industry products and from competitive markets. They're paying about 1.3 times international reference prices on average for the drugs that were in this study. On the other extreme, Zambia, Laos, Kyrgyzstan were buying in small volumes, not preferentially for generics, importing, and not in competitive markets. And you can see 4.6 times the international reference price. That's huge. That's a huge difference. So if you just imagine if they could just break down 10% of that purchase into something that's more efficiently procured, there's huge gains to be made. And all that money then available from better health services. On the right-hand side, a study from Chile about prices of pharmaceuticals. This is in private pharmacies. Depending on the drug, this is the ratio of the original brand that's on sale to the bioequivalent generic. So it's like looking at gasoline prices in the United States. You go to one place and it's $4 per gallon. You go over here, it's 25 cents per gallon, and people are continuing to buy the $4 per gallon gasoline. Why? And it comes down to a lot of reasons, but the efficacy and the safety are supposed to be the same. If people knew that, why would they be buying more in the private pharmacies? Even more of a question for the public sector. Why is it buying branded when a generic is equivalent? And as you can see for this ulcer drug, the ratio is 32 to 1. That's 32 times the price. This is a simulation that you'll find in the publication where we just went through some of these strategies. For example, on switching to unbranded generics, we just assumed that the government switched 50% of its purchases of branded drugs to generics. And the governments of the region collectively would save about $3 billion. $4 billion for households buying things out of pocket. The $3 billion that governments would save is equivalent to other services they could provide that would add about 10 or more healthy life years for 60,000 people in the region. So these are not small numbers, and these are relatively easy bureaucratic administrative things. Since I'm short on time, I'm going to rush ahead a little bit to this slide, which is, to me, one of the critical things is it's one thing to know the technical solutions. It's one easy thing to say, look, this is so obvious. Why aren't you doing it? Well, why aren't you doing it is because this is a large political economy question. When you spend smart, you're making choices that are different from the way the choices are being made today. And typically, someone is going to either end up with fewer profits or a lower income, or they're going to be excluded from a treatment that they think they need. And those are the three things that governments are against politically and publicly when they're making smart health decisions. These are four of the strategies we talk about in the report. You can mobilize groups to support smart spending, and you have to mobilize them explicitly. They won't do it on their own. Finance ministries clearly have an interest, as you saw when those two ministers who looked strangely similar were debating. In the case of businesses, is it possible to, in terms of weakening the opponents to smart spending, is it possible to break apart the business community from those who want their employees to have access to better care and lower cost information from the ones that are trying to maximize their profits in pharmacy inputs and services in the health sector? Can you neutralize opposition? Famously, when the U.S. reform went through under Obama. He chose not to fight the private insurance companies, which are very strong. And he made some concessions, but in return, he got the fact that insurance was going to be mandatory for all Americans. That was a key, important step forward toward universal health coverage the United States was never able to make. And by offering some concessions to the opposition, he was able to achieve that particular gain. So you have to decide what are the relatively insignificant concessions you can make in order to get the big ones that you hope will unleash very positive change in the future. So smart spending is the key to the right to health, to progressing toward universal health coverage. There are these many ways of spending smart. We can promote it by clarifying responsibilities, improving information like cost effectiveness data and trade-offs, assuring that insurance institutions have compatible mandates, linking technical analysis to political processes, and making sure the public understands these things, and then limiting conflicts of interest and vested interest. And with that, just a call to head to Red Criteria, the website, for lots of details on good tools, good information for this kind of work, some great videos, courses. The Social Protection and Health Division at the IDB also has a lot of work on this kind of material. And of course, please read the report. Thank you.
Thank you, Bill. Thank you for that excellent presentation. That was an excellent presentation with very concrete examples, good illustrations of how some of these strategies to improve spending can produce major results in terms of the healthcare systems in the region. So now we're going to have a conversation, a panel, with our guests to talk about the political economy of some of these decisions. We know that implementing some of these strategies is quite challenging, and we're going to be talking about some of these aspects here as part of this panel. So I would like to begin by inviting our guests. We have two ministers of health from the region, so I would call on Dr. Mary Manivar, who is the second Vice President and Minister of Health of Costa Rica. Also, Dr. Karina Rando, who is Minister of Health from Uruguay. Also, Amanda Glassman, Executive Advisor of the Inter-American Development Bank. And lastly, Bill Salvadov, who is going to be part of this discussion. Thank you. Okay, I would like to start by talking a bit about smart spending for health is important, and it has the potential of producing major impacts. But why is it so hard in practice to implement some of these strategies? I would like to begin this conversation with you, Dr. Mary. Tell us, why is it so hard to realize the potential of these policies? Well, first of all, good afternoon. And I think that in the introduction, they hit the nail on the head. We do have fiscal constraints in Latin America. And also, hopefully, we've left the pandemic behind us, but nonetheless, that pandemic affected a lot of our economies and also brought many health challenges because other pathologies were not being dealt with, and now we have to make up for that. Plus, we have strategies where we have to look at change management as new technologies, new innovations are being introduced, and that handling change requires effort, time, and at least in my country, in Costa Rica, we have a law that to a certain extent compels us to do budgetary projections to 1 year. And in health, sometimes it's not easy to do that type of projection. A lot can change in 1 year. And consequently, we have a hard time visualizing what may be coming down the park. Now, we have variants that are affected also because of migration, and that also affects the budget. And we have to invest to maintain public health, but these are expenses that have not been budgeted, or we don't have a contingent budget item. So finding that balance between what we have to address, the needs that we have to deal with, we have to balance that against the country's needs, looking at finance too. Now, also, Dr. Karina Randall, would you like to talk about why it's so hard to implement these policies? Well, first of all, thank you. Thank you for the invitation. This has been a very stimulating seminar. But I do have some ideas about why it's so hard to implement these policies in Uruguay. One of the problems we have is the existing regulations. Sometimes we cannot redistribute funds from one type of service to another. I could give you an example. In our country, public health is managed by ASE. It is the National Health Service, and they cannot hire staff freely. There's a whole bureaucratic process, and the legislature is very strict, and they cannot hire staff. Now, in the case of Uruguay, intensive care beds, sometimes we have hospitals where people are certified, but those beds are empty, but there's no staff. So what does the hospital have to do? Buy beds in another institution, because that is allowed. We cannot buy services for intensive care within the same hospital. So that is just an example. We have many examples that are similar. And behind that is the inflexible rules and regulations that exist in Uruguay. I can give you another example, something that is very interesting, and that is the cultural effects that are believed in by the population. Our population in Uruguay is used to not going to a general practitioner if they have a sore back. They go directly to an orthopedist, a traumatologist. So that traumatologist calls for a scan, and if he would have gone to the general practitioner with no tomogram, no CT scan, he would have felt that he did not receive good service. So those are two examples. Amanda, would you like to reflect on this question too? Yes, I think that one thing is that not necessarily are we measuring or analyzing the problems of efficiency. We're not doing so systematically. So this problem is invisible. Despite the nice examples just given to us by Bill, this type of thing is discussed in the academic world, or it's in some paper, but it's not on the front page of our newspapers. So it's really hard to assess efficiency in an ongoing public way. And sometimes they're a very interesting experience in terms of accountability or publishing results. Some things have been successful, others have not, or some things come and go. So that is work done by technical people. They have to publish their results, make them known. And sometimes we talk about efficiency gains, but it's in the abstract. So the per capita expenditure that saves X number of years of healthy life. Here we have heard different examples about problems that have three aspects. They're costly. Also, there's a problem in terms of being able to act within the system, and they are issues where the person has no control to be able to change the situation because of regulations, because of practice, because of professional constraints within the procurement system. So we also have to be able to think about the subset of reforms that are going to be important, but this is something we can control so that we can execute them within a reasonable period of time. So it's important that we make headway there. That's a very valid point, and it involves a lot of players, right? And that, too, brings certain challenges. Now, and Bill, in your presentation, you talked about the factors. Would you like to give us more information about some of the effects?
Estas intervenciones ya tocan en el punto central.
I think that what was said here really is quite relevant if there's a bureaucratic constraint, something that affects the whole system. And my question is, why can't you change that? And I imagine that there are two things, two types of pressure. On one hand, you have people who are used to the system as is, the antibiotics, the CT scans, etc. And on the other hand, you have people that are thinking of the impact on health. But the people who are in favor of business as usual are very aware of what is happening. And if there's a change, they're going to resist. Whereas the public, others, have no information, no interest in changing things. So in terms of a path forward, we have to find a way to mobilize the public by showing them what the impact is of limiting the ability to hire or being able to order a scan. If that's not fully justified, you would have to create a partnership with the public so as to assure more efficient spending. Thank you. That's a very valid point. Dr. Karina, one of the main recommendations in this publication has to do with disinvesting in activities that generate little health value and to support interventions that are highly cost-effective. But we know that there are constraints, and you just described some of the difficulties in assigning these resources as part of the health budget. So I wanted to ask you, how can we deal with these constraints? Are there any concrete actions that could be implemented so as to facilitate reallocation within the healthcare budget? Well, that's the situation. Sometimes reallocating budget for actions, activities that are of very little effect are resisted. So we see there's a political cost in Uruguay. If you take funding away from a given activity, although you may have very few patients that are actually benefited from that action, they will be talking to the press, they will sue, and the political cost that that causes, in other words, the government took a right away from us, that is important, especially right before elections. Uruguay now is 1 year before elections, and the fact that we reallocate means that. It means that we're going to have to pay that political cost. So one way would be to provide information correctly, but it's hard for the population to understand what an opportunity cost is, because here what we're doing is we are spending inefficiently, and consequently the opportunity cost that we have is enormous, because with the amount of money we have, I can share with you a case that was in the media last week in Uruguay. and it was chondroplasia. Chondroplasia, you're acquainted with it, and a new drug comes out so that the child or the patient will be growing 1 centimeter per year up to the age of 16. Now, if you cost out that use, it is $2.5 million in that period of time. And when we received that request, the minister said, no, we need $2.5 million to reallocate. But we wanted to support the mental health campaign. And with that money, we could reduce to zero the co-payments of the 2 antidepressants that are being used for the population. So we aren't able to use the funds for that purpose. So the opportunity cost was huge. What happened? The press began to provide information regarding this. They published information on this little girl. So they saw her face, they heard about her case, saying the Ministry of Health does not want to give the medicine to this girl. So how can you explain that it's not that we don't want to give the drug to this girl, it is that I want to give antidepressants to the 2,500, 3,000, 4,000 people who need the antidepressive. So that is our major problem. And I think that education is one of the things that we can turn to, but we'll be looking to the publication for some strategies that might be helpful. Okay, so opportunity costs, we need to make that ever more visible. We have to explain how hard it is to make these decisions, how we cannot finance very expensive drugs because we have major coverage gaps in essential services. So that's a very important point. So we need to involve the population, share this information with the public. Dr. Mary, this publication, as Bill was saying, focuses on 3 major things: buying the right things, spending less on poor inputs or services, and making better deals. But there are other strategies that are also helpful and help us improve our spending for health. We were talking before the panel, and you were saying that in Costa Rica you're implementing a series of policies aiming in this direction. Could you share some of these policies with us, things that you're working on right now? Thank you. I don't know if you could project the slide, but this is helpful to understand the context in Costa Rica and what our health sector is. Article 21 of the Political Constitution says that the right to health is a constitutional right. So we have to give the opportunity to the whole population and deal with the population in an equitable way. Now you can see that the Ministry of Health is the big part. And here we have also the Social Security Institute, plus we have different insurance agencies. We have AIA, which is water, and Cienza, also the part with recreation, Alpha, that is drug dependency. So all of these things come under the health sector, in addition to research and other things. So this is truly a monster in terms of service delivery, where we have to reach the entire population. Now, obviously, there are some factors that are more preventive in nature. We're focusing on that. But on this next slide, there are 4 lines of work. 3 of them we're already working on. And why? Because wearing another hat. I took the office of minister on the 10th of May. Now, we do have a government plan. We had reviewed a lot of information. All countries pay for consultancy services, do analysis, but when you are going to implement, sometimes you hesitate. So when they said, okay, we need to look at ways to implement what is needed, that is digital health, effective medicines, and environmental health. Let's get started. And in clinical studies, and of course, I strongly support research, that is where we wanted to provide the different enablers so as to do research in the country. So everything having to do with rules and regulations has already been generated. Also, this is ready to be enforced, applied. So we can do phase 1 studies and bioequivalence. That goes hand in hand with effective medicine. Why? Because we have, since 1997, the Social Security Institute provides coverage to 99% of the population. And Social Security gives services and also the medicines. And we had to update the formulary. Even though there were products on the formulary that were no longer effective. So we analyzed the 100 elements on the formulary. We looked at active ingredients, and we are looking at all of the chronic and non-communicable diseases. So here I would say that Marta, who leads the Social Security Institute, can proceed to buying the medicine. Now, we began to work towards attaining level 3, and we want to have quality, safe, and effective medicines and opening up competition so as to force costs to go down. Also, there was re-engineering internally so as to be able to deal with the accreditation of different regulatory entities, and all of that will facilitate increasing competition. And regarding digital health, on Friday, we will be launching a bill on digital health, and this is promoting change. Why? Because using artificial intelligence, some alternatives that have been used to provide services for a long time, helping us lower costs, were not regulated, were not being overseen. So we need the Ministry of Health to be helpful. This approves early alerts for prevention and promotion, and also it lowers costs. We have something that works in our favor, and that is the single health history. And that was approved 11 years ago by the Congress, and now it has to be implemented across the entire country. And we are doing this with Social Security, and that lowers costs. How? Often we go from one institute to another that's also state-owned, and we have to again do studies. We have to again prescribe certain drugs. Also, drug dependency. Sometimes we find that patients know that there is no sharing of information, so they ask for drugs to control their habit. Now, this is something that was only on the books, but now it's being put into effect. And so digital transformation, having passwords so as to be able to control everything in terms of timing, that is part of the actions we're taking. Thank you. Bill? What are your 3 main recommendations for the countries in our region that want to improve the efficiency of their spending for health?
Quick wins and on to the longer term. So the first thing, generics. Just push as much of the public budget into buying generics and not buying branded as soon as a drug is off patent. And that can't be a passive policy. There are a whole series of active policies you need to make that happen, promoting competition, educating people, making sure that when you say these things are equally effective and safe, it's really true, right? Without that, you will never get the confidence to make it happen. So generics, number one. Number two, procurement. It'll be different in every country, but making larger volumes, either by pooling procurement within a country, centralizing some part of procurement, or working with other countries. The region as a whole, if it bought drugs internationally, it has a market of 650 million people. That's a large volume. If it's doing it for a 3 million person country, it doesn't have the same market power. And any procurement procedure that improves competition is going to get you better prices. And so that's sort of a medium term. And then the final one is health technology assessment institutions, not as technical institutions, but as institutions that are embedded in the public discussion. So these things about trade-offs, where they can do the calculations, but then have some way of linking to the marketing arm of somebody who says, okay, yes, we're not getting this particular drug for cancer, but here's the 5 people who are now going to get screened for diabetes, or who are now going to get some other treatment, so that you're putting a face on the trade-off. So making the health technology assessment institutions there, making them strong and capable, and embedding them in the political and public process of debate.
Thank you very much, Bill. Excellent points. Amanda, would love to hear your thoughts on the same question.
Well, I'm sure that you already heard about it from Ursula and Javier, and it builds on Bill's last point. But the importance of institutions and fair process that's accountable to the people seems important to me. And it's not just, I think there are lots of different institutional choices you can make about the architecture, whether it's a separate health technology assessment agency or whether it's in your own budget and evaluation office within a ministry. But I think the point is to make decisions about the lowest cost, highest impact strategies easy and routine. Can we do that? I think that is the challenge for all of us. And I think, when I started working in Colombia with Ursula and Javier so long ago, we brought the UK's National Institute for Health and Care Excellence. And then we all got bored with the example of NICE. And then NICE has weakened in terms of its function within the UK national health system. But I think what was so interesting about the NICE experience is that they had patient boards that would meet. And it doesn't say the patient group is not my enemy, industry is not my enemy. They are legitimate interests in a political process that is budget allocation. And therefore, I have to have a process that involves them, hears them, weighs the evidence, and then takes a decision based on the public interest. So defining that public interest and hardwiring it in our institutions and budgets, of course, that's an ongoing challenge. But even in the United States, we're seeing progress on this. That's kind of exciting, that actually cost effectiveness of medicines, the cost that we pay for pharmaceutical, we can now, as the U.S. government, as a purchaser for elderly people and for our Medicaid program for the poor, we can negotiate with pharmaceutical companies. And that happened only in the last 5 years. So, that sounds crazy probably for people who negotiate cost all the time, but that was how it was in the United States, where the interests were not controlled. And it's because of these processes that are starting to weigh costs and benefits in the public domain in conversation with all parts of the health system.
Excellent. Thank you so much. I think these topics of making sure the legitimacy of some of these decisions and the processes indeed coming across very, very loudly here and very important. Doutora Karina, ¿qué tipo de apoyo concreto?
What kind of specific support, when we look at multilateral organizations like the IDB, what kind of support can they provide in order to achieve the agenda of smart spending for health? Okay, so now we're reaching the point of requesting the IDB, working with Latin American and Caribbean countries, can help to facilitate various initiatives, facilitating access to experiences gleaned from other countries, maybe in Uruguay, We in the South may not find out what's going on in Costa Rica. We may not know what the IDB did to support Haiti and other countries. So some of these experiences could be very valuable that we could share. And I think the IDB could serve as that conduit for articulating many of these experiences. And then if we look at one very specific area that's very valuable, has to do with funding and assistance provided to countries through these consultantships and with the national level diagnostics, where later decisions, well-informed decisions, can be made regarding the Sustainable Development Goals. For example, there are various measures that are straightforward and easy to calculate exactly how much we can get in savings through the use of generic drugs. We need to make that fairly clear, because if we need to make our legislation more flexible so that we can increase the use of generic drugs, studies such as these can help to convince policymakers to move in that direction. Similarly, the calculations regarding these some of these thresholds could be a very specific way of providing assistance. There are less precise ways of calculating these measures of and thresholds. These are guides that could be supported with the involvement of the judiciary. So if we have, for example, a country like Uruguay with 12 or 15,000, which is a little less than GDP per capita, and these medicines cost 5 times more, maybe it's easier if the judicial branch understand that this may not be the best alternative. So I think the calculation of these thresholds is essential. We should also point out that the support that Uruguay has received in their experience in terms of information technology, the development of information technology is essential to improve effectiveness, because we have developed, for example, entire clinical history so that resource. So, for example, if a patient goes to, let's say, goes from one town to another 600 kilometers away, the physician that can attend to that can look at the electronic records and understand, see exactly what the clinical history is, what studies. Maybe they don't have to take scans, they don't have to do any blood tests because they're already available in a clinical platform. This is a national level platform. So I think the development of IT, technology, and health is essential. And I think in that regard, the IDB would be a major source of assistance. Thank you. We've taken note of that. Mary, in your opinion, what kind of support can the IDB provide in helping countries throughout the region? Well, I don't want to repeat everything that was already stated by our colleague, but I think some key points. For example, looking at the high costs and some of the challenges that we face in keeping and retaining our specialized staff and talent. And we need to be able to provide access to specific programs so that we can retain our professionals. And I think the experiences of, for example, the community nurses, that's very valuable. So I think we need to look at the profiles. We need to look at the skills that can be optimized among our healthcare staff. Also in communications, we see how frequently actions are executed based on specific challenge that is data supported, but the public perception regarding solution is not what was expected. So in order to get better treatment in healthcare facilities, how can we, for example, make sure that our target audience get a perception of all of these strategies that were implemented? Because based on evidence, this is what's best for addressing their interests. So I think what Federico indicated, I think, is very valuable, where we have discussions with the technical staff, but we also need to get feedback from our our target audience to get so that they get a better awareness and understanding about these alternatives that have better supported them. Thank you. And now, as we conclude, I would like to just pose one final question to Amanda. Amanda, we talked a little bit about this in the panel, but I'd like to hear your opinion. In the region, there are many initiatives, regional initiatives, that have allowed us to move forward in advancing various healthcare agendas. Now, if we look at efficiencies, what are 3 recommendations that you would give for countries as far as specific measures that could be implemented regionally in order to advance our agenda in efficiencies in healthcare? Well, I think when we look at, for example, the joint bidding processes in procurement for high-cost drugs, and maybe other countries can join into these initiatives. Other regional measures, for example, preparations for pandemic, if there are ways of conducting, for example, clinical trials, and we haven't, for example, tested new vaccines for chikungunya, and I think this can be done jointly, perhaps with small groups of countries. And if we just follow up what's been done as far as the exchange of experiences, listening from experts from throughout the world, and have this learning experience, mutual learning, and I think we've all benefited from these initiatives. Thank you very much, Amanda, and I totally agree. Thank you. Bill, would you like to add to any of the reflections already expressed, or as far as cooperation?
Almost like a public call to action, and the IDB is part of this, but so is PAHO and any of the regional initiatives. This is the first region in the world that eradicated polio. It's the first region in the world that eradicated smallpox. And PAHO has these purchasing funds already, the revolving credit fund. So we have an incredibly rich history of public health institutions being developed and of collective action. I was extremely disappointed by the way the region responded to COVID. The region, if it had responded as a full 650 million strong group of countries, could have played a much larger role in the market for vaccines and in the response to the disease. So with that as sort of like a call to action, along with what Amanda was saying in terms of procurement and joint procurement, standard setting, regulation of drugs and approvals, if that could be done collectively, it would be great. And as digital health is introduced, doing that in a standardized way so that we don't end up with 26 different electronic health record systems or something like that. There's just so much that we can do better together than we can do alone.
Muchísimas gracias. Sí, unidos somos más fuertes, ¿no? Como dice el dicho famoso, y estoy muy
And
de
as the
acuerdo.
saying goes, you're right, that we're stronger when we're united. So I think we've reached the end of this panel discussion. I want to thank all of you who joined us, both here at headquarters and also virtually. I'd like to thank all of our panelists, and I'd like to encourage you all to download our publication, to review that publication, to get in touch with us. Maybe we can get into new discussions and dialogues so that we can work together on this agenda. Thank you very much.